Then today,
Sir,
I am, yes, please.
I have a question.
Yes, please.
We saw that in some cases, some medicines used or chemotherapy used in cancer treatment, like alkylating agents, can result in a patient getting secondary malignancies. Are
Yes.
they still used as first line therapy despite this shortcoming?
Yeah, by the way, most of them, they are, remember in cancer, monotherapy is very minimal. Like the role of monotherapy is actually, but we are still using alkylating agent. Yes, despite they are actually causing. Remember, it does not mean that like it's just like one of the risk, but it may cause or it might not cause. So we are still using alkylating agent in the management of like different malignancies. Yeah, that is true. If you see even like cisplatin, by the way, the platinum analogous, more or less the mechanism of action is like alkylating agent. So they are the most commonly used drugs in management of solid malignancies. So that one is like the major limitation of anti-cancer drugs. So the only way you just monitor the patient. Yeah, that is the only way you can do. Mm.
Okay, so thank you.
Thank you. Fine. By the way, I have seen like the active participation in the semester is like dramatically improved. And that is good. Yes. So as long as we spend time by there, we want to do some other activities during class time. It is very, I know we cannot see it each other, so we cannot control. So you just normally do self-control as much as you can. So during the class time, yeah, despite you get bored, just try to concentrate. Yeah, maybe you take tea, increase something that actually increase concentration like coffee and tea. So those are very important because they promote the release of catecholamine, so it increases concentration. I think that is very important because for sure, like at each point in class, you will see something new, especially in cancer treatment. Okay, so I'm still encouraging all of you to attend as much as you can. So today, we're going to discuss about the management of chemo or therapy related ADR. So at the beginning, I mentioned cancer treatment or cancer treatment modalities like the chemotherapy ones, they are actually having narrow therapeutic index. So because of that, undesired side effects or undesired effects of the chemotherapy is very common. So this is what we are going to discuss now for today's session. How do we manage at least the most common chemotherapy related adverse drug reaction? Okay, so patients with cancer, remember, there are high risk of adverse event resulting from the treatment, but even the cancer itself. Okay, but when you say adverse drug reaction, we are just referring to as a result of the chemotherapy and even the radiotherapy. Then, what are some of the treatment-related complications? Nausea and vomiting. By the way, this one is the most well-known side effects of chemotherapy. Nausea, vomiting is actually very common because most of anti-cancer medications they do have higher emetogenicity potential. They can actually increase the release of serotonin from the GIT. Then ultimately, serotonin is the main neurotransmitter that can actually activate vomiting center. Then nausea and vomiting is very common. So it is good to know how we are going to manage nausea and vomiting as a result of cancer chemotherapy. Then the other thing you are supposed to know is myelosuppression, febrile neutropenia, then hemorrhagic cystitis. I think we have seen the oldest alkylating agent can cause some kind of lesion in the bladder and ultimately causes bleeding, mucositis, and tumor lysis syndrome. Okay, so those are very common. By the way, like the tumor lysis syndrome, we're going to discuss in oncologic emergency, but this one stands for when you give treatment for chemotherapy, highly sensitive tumors such as like lymphomas, they actually like suddenly undergo breakdown and release of the cellular content and causes a lot of electrolyte disturbances, including acute kidney injury. So that syndrome as a result of chemotherapy use is known as tumor lysis syndrome. So this one we are going to discuss under oncology emergency. So the main focus for today will be about the other ADRs. Then the management of the complication for this case is usually supportive care or symptomatic management. So those are the strategies we are going to use. Then the first one, in which is the most prominent, like that of nausea and vomiting, is the myelosuppression. And most of the time, myelosuppression is one of the dose-limiting toxicity because it is mostly associated with the dose. Okay, then it can occur several days to several weeks after treatment, and it varies with chemotherapy. But you expect, by the way, like the within 2 weeks of treatment, there is a possibility. Then, when there is a myelosuppression, remember, anti-cancer drugs will not distract the already existing blood cells. Rather, it actually causes suppression of the bone marrow and inhibits further production. So ultimately, when there is a myelosuppression, it can actually result in reduced neutrophil count. We call it neutropenia, thrombocytopenia, reduce in the platelet count, and decrease in RBC. And this one is related to one of the cause of anemia. Then remember the timing of the occurrence of neutropenia, thrombocytopenia, and even anemia usually differs. So why? Depending on the lifespan. Remember, like depending on the lifespan, like most of anti-cancer drugs, they don't really significantly affect the already existing blood cells, but it can suppress the new blood cell formation. So the already or the existing blood cells is supposed to be depleted in order to cause myelosuppression. That is why, depending on the half-life time or the lifespan of the blood cells, you will see a difference in terms of timing of those ADRs. For example, if you give a certain chemotherapy regimen for a patient, let's say adramycin and cyclophosphamide for breast cancer. So if you give them, the first thing that can happen within 6 to 12 hours is usually febrile neutropenia because the neutrophil count usually have, or the neutrophil they normally have the shortest lifespan. So because they do have shorter lifespan, that means the moment you give chemotherapy, they are actually the first to undergo depletion or suppression. So neutropenia should happen first. Then the thrombocytes normally they do have 5 to 10 days. So the already existing blood cells to deplete, it will take 5 to 10 days. So we're expecting platelet like thrombocytopenia after 5 to 10 days. Then anemia will occur last. By the way, the moment you give chemotherapy, don't expect anemia to happen immediately because the RBCs usually lasts like 120 days. That is equivalent to uh, uh, that is 120 days is equivalent to is almost 34 months. Huh? Yeah, 4 months. So because of this half-life time is longer, it will take longer time for the patient to develop anemia. That is why the moment you give chemotherapy, assess the risk of your neutropenia within a few hours, then thrombocytopenia maybe after a week, but anemia after 3 months later. Then this one will depend on the type and the dose of the chemotherapy regimen. But in terms of order, neutropenia happens first, thrombocytopenia follow later, then anemia will occur last as a result of chemotherapy. Okay, that is why the effect of myelosuppressions are not observed immediately after administration because the currently circulating blood cells must be consumed first. So that is why there is a difference in timing depending on the lifespan of the blood cells. Okay, good. Now, how do we prevent myelosuppression? So myelosuppression can be prevented by giving or colony stimulating factor, which normally increase the production of granulocytes. But from the colony stimulating factor, the most common one, which is available locally, is filgrastim, is the most under the brand name Nipogen. Nipogen is the most commonly used drug that can be given subcutaneously in cases of myelosuppression. So by increasing the production of granulocytes, it can shorten the duration and decrease the magnitude of febrile neutropenia. Then thrombocytopenia can also happen. We can actually even consider platelet transfusion, but in our setting, mostly if there is a thrombocytopenia, whole blood transfusion is the most common, but it is usually advisable if the problem is only platelet, you just give platelet alone. Then anemia is also a significant side effect. Treat with epoetin, and the erythropoietin products are mostly used in management of anemia due to chemotherapy. But in our setting, mostly they usually use transfusion. If in case if the patient develop anemia because of I don't know, it is because of availability issues, they normally use whole blood transfusion. But this epoetin and epoetin will be the prominent treatment in anemia due to anti-cancer medication. But remember, treatment will continue only until the bone marrow restore its normal production. The moment it is restored, you normally discontinue the treatment. Okay, now that is all about myelosuppression. The other thing which is very common is oral mucositis. This one, by the way, you cannot even miss every day as a result of chemotherapy. So this one is defined as there is erythematous and ulcerative lesion of the GIT following chemotherapy or radiotherapy. Yes, or maybe high dose of chemotherapy. So there is anyways ulcerative lesion as a result of therapy. So because the mucosal lining of the GITs, including the oral mucosas, are the prime target for treatment-related toxicities because they are rapid cellular turnover rate. They are actually all the time in active growth and proliferation. Because of that, the cancer cells even usually like us the highly proliferative cells. That is why the GIT and the oral mucosa is usually highly affected. So mostly like those drugs which are stomatotoxic and radiation therapy of the head and neck region can actually even cause this problem. By the way, especially for neck cancer, head, neck, and even esophageal cancer, the most common treatment is usually radiotherapy. The moment you radiate, you can actually even cause destruction of the thyroid gland, and hypothyroidism is usually very common after radiotherapy of the neck. In fact, that is really the major challenge and one of the major limitation of radiotherapy because you are treating the cancer, but as a result of the radiotherapy, now we are going to develop another condition which is known as hypothyroidism. So it is very common. Okay, so this one is very common. Then mostly it usually occur 2 to 3 weeks after treatment commencement. Maybe even may last 2 to 3 weeks after completion of treatment. Then the radiation-induced mucositis is more severe and longer duration, so it can stay even up to 12 weeks as compared to chemotherapy-induced mucositis. Okay, yes. Then if a patient is undergoing combination therapy, now the commencement time will be shorter. Like instead of occurring 2 to 3 weeks after treatment, it can actually even happen within a week time. So the higher the dose of the chemotherapy, like the lower the timing it occur. Yeah, the sooner it will occur. It's very common. And this one also exacerbate severity and prolonged duration of treatment. So in short, mucositis means if there is an inflammation, then as a result of inflammation, there is a possibility of ulceration of the mouth, esophagus, and lower GIT. Then because of that, there is infection and pain can actually happen. Then as a result, there is decreased fluid and nutritional intake of the patient. So what are the most offending drugs that can cause mucositis? Those are the most common offending agent: methotrexate, 5-FeO, etoposide, doxorubicin are commonly associated with mucositis. So you expect ulceration in the mouth. It's very, very, very common. Then, what are the signs and symptoms? But of course, redness throughout the oral mucosa and ulceration, as well as pain and altered taste is very important and very common. Bleeding can sometimes happen because of ulceration. Nutritional intake will be lower, then subsequently there is a possibility of weight loss. Then, apart from that, it can increase even risk of opportunistic infection, mainly bacterial infection. Okay, then now if we know the drug is like the 5-FU, then the other medication, the doxorubicin, especially 5-FU, methotrexate, if we know the drug, we can actually use prevention modalities. So what are the most common prevention modalities? When you give a bolus dose of 5-FU and high dose of alkylating agent melphalan, it is good to consider administration of oral cryotherapy, or we call them as chips, like 50 minutes prior to, during, and up to 1 hour after the infusion of the anti-cancer medication. So the rationale behind this, remember the cryotherapy means like it is called cold treatment. So the moment you give cryotherapy or as cheapest to the patient before the chemotherapy, because of vasoconstrictor effect, it reduces the delivery to the mucosa, the oral cavity of the mucosa. Yeah, the mucosal part of the oral cavity. That is why oral chips are usually recommended to prevent mucositis. Then, apart from that, good oral care during therapy is very important. So, brushing with a soft bristle toothbrush at least twice a day is usually recommended. By the way, if someone is having even bleeding disorder, it's usually advisable to use soft brushes because if they bleed, it is very hard. Then, even in case of cancer treatment, they are supposed to use soft brushes so that they cannot cause some kind of ulceration, which can worsen the condition. So those are the prevention strategies we are going to employ when someone develop oral mucositis. Then, in treatment wise, in case if oral mucositis happen, the only way is just symptomatic management to alleviate symptom and avoid secondary complication, dehydration, and etc. So still, the most common recommendation is maintaining good oral hygiene. So hygiene of the oral cavity is very important. Then apart from that, maybe we can consider some pain medication, then also even antifungal medication, as well as, yeah, antifungal medication can be given to prevent the possibility of secondary complication. Remember remember the moment you are actually reducing the moment you are giving chemotherapy, you're actually even suppressing the immune system of an individual. So there is a possibility of even growth of the normal flora in the oral cavity, such as the Candida albicans can even cause some kind of oral candidiasis. So that is why nystatin, clotrimosoles are usually given for these kind of patients. So this is all about oral mucositis. So in short, prevention like cold cryotherapy or ice chips during, before, after treatment, so that it causes vasoconstriction and reduces delivery to the oral mucosa. Then treatment-wise, symptomatic management, good hygiene, then of course you can consider painkiller and antifungal medication. Now, alopecia. Alopecia is very common as a result of chemotherapy. I don't know. Have you came across maybe any patient who had alopecia as a result of chemotherapy? Anyone who came across?
Yeah.
Okay, what type of cancer the patient was having?
It was CLM.
CML?
Yeah.
Is it CLL or CML?
CLL.
Or CLL, okay. It's not very aggressive. Huh? But does the patient survive it or
No, she died.
at the age of what?
Uh, 30 something, I think.
Oh, okay. Mhm. By the way, the mean age of diagnosis is like about 50 years anyways. It is very common in adult population. Huh? Okay, anyways. Huh? So it's just one of the type of leukemias that is affecting the lymphocytic lineage of the bone marrow. Okay, by the way, alopecia is actually hair loss. It is very common. Sometimes partial, but some of them they can actually cause total alopecia, like the taxane. Hey, by the way, if you see taxane class of drugs, they can actually even cause total alopecia. But the beauty is, mostly most of them, the alopecia is not permanent. The moment the patient stopped the treatment or completed the treatment now, the hair will come back, but it will take some time to fully recover. Yeah, for full recovery, it will take some time. So, what is the negative impact of alopecia is the individual perception and sexuality and self-esteem and body image, especially in ladies. I think that is why I think I mentioned somewhere when you give cancer chemotherapy, most of the time the doctor they just recommend they want to shave like the hair. That will be the easiest way. Instead of having this kind of hair, you better shave and look like just to maintain the uniformity. So can you see normally the difference? This one is before chemo and this one is after chemo. It is very incredible normally like the patient here fall off like from this to this, but it does. Yeah, but it does. Yeah, you will see several patients. So maybe in the future, remember because of COVID distraction, we really didn't do like hospital rotation to integrate the theories. That is why I usually say in the future. Okay, so that is the only negative impact. Otherwise, there is no issue of alopecia except the psychological impact itself of the patient. Okay, why alopecia is very common? Because hair follicles are usually rapidly growing all the time and they are highly sensitive for chemotherapy. And chemotherapeutic agents, they are very specifically targeting highly dividing cells like the hair matrix cells. That is why there is actually there is a possibility of partial or total alopecia. Okay, can actually even say 80 to 90% of the hair follicle are inactive growth phase at any time. That is why they are highly susceptible. Then the hair follicle will resume, but within 6 to 8 weeks after treatment has completed. But for full recovery, it will take 3 to 5 months. Yeah, it will die off within short period of time, but it will actually take longer time for full recovery of the hair growth. So this is not something we are going to worry about, and we have to give proper instruction to our patients. Then, like most commonly, chemotherapy-induced alopecia affects the scalp hair, the beard, and the eyebrows. However, axillary, pubic hair, eyelashes may also be affected, but mostly by the it can actually even distract any hairs anywhere in the body system. But mostly this area is commonly affected. Then, as I said before, the majority is usually reversible once the therapy is discontinued. When the therapy is discontinued, there is high probability of reversal. However, And there are some reported cases of permanent alopecia with the use of epidermal growth factor receptor, EGFR inhibitors, and high dose of chemotherapy. Like taxane is not permanent, but it can actually cause total body alopecia. Okay, so that is how it happened. Remember, the higher the doses, the higher the risk of alopecia. So you have to know that point is also very important. Okay, then the combination therapy is more likely to cause total alopecia than the single therapy. This one is related to the synergistic effect, and most anti-cancer drugs that damage the hair follicle and produce hair loss, especially it is cyclophosphamide, doxorubicin, vincristine, methotrexate, and actinomycin D. They are actually notorious to cause hair loss. So this is some of the lists we are going to watch out. But this one is not really something we are supposed to worry about because we need to tell them just have, then after that it will come back normal after completion of the treatment. So that is very important. Then another point to note is radiation-induced alopecia. So by the radiation-induced alopecia is also very common when the patient is getting radiotherapy. Yeah? Remember, radiotherapy is actually one treatment modality because the radiotherapy normally they emit beta radiation, by the way. Yeah, like the gamma one is mainly for imaging, the beta one is usually for treatment. Yeah, this one gamma is for imaging, diagnostic, but the beta radiation emitting radiation sources are usually they are important for treatment. So radiotherapy by they generate free radicals. By generating free radicals, they can actually directly kill normal cells as well as cancer cells. So that is how it works, and it also affects uh, the uh, the hair. There is a possibility of hair loss, and as we said before, the duration of alopecia is usually very longer with radiation treatment. But remember, the hair loss is at the site. By the way, like in cervical cancer, most of cervical cancer patients, when they are locally advanced stage, they are usually treated with chemo radiation. There is a chemotherapy component and there is radiation component. The chemotherapy component is usually cisplatin. So this cisplatin, we call them radiosensitizer. That means it increases the therapeutic effect of the radio therapy. So in that case, you are going to see normally alopecia from the site of like the radiation. So this one is not something we are going to worry about. Like if you give chemoradiation therapy for cervical cancer, the only hair loss is only in the private part, like in the pubic region. Otherwise, you don't expect hair loss in the hair. So radiation therapy is usually we are going to see hair loss from the site of the treatment mostly. Okay. So hair loss may continue once the treatment has completed. This is another important information to note. Okay, then, what are the signs and symptoms of alopecia? We have already said it can be thinning of the hair, breaking, sometimes even partial loss or total loss, mainly due to taxane and cause total alopecia. Okay, otherwise, there is no like any discomfort when there is loss of hair, but rarely like pain in the hair follicle when the hair falling out. Otherwise, there is no specific clinical or any discomfort as a result of hair alopecia due to chemotherapy. Then, how do we manage? But then, as of like based on the latest information I have, there is no any specific treatment modalities that can specifically target hair loss as a result of chemotherapy. So currently, there is no pharmacological molecule that decreases the risk. However, there are some strategies, but we don't have in our setting, by the way, that when I was doing a rotation at TNH, one oncologist from the UK told us these techniques are usually commonly practiced in the European countries. Like where he was in the UK, they have been using cooling and tourniquet so that to reduce delivery. So the whole idea is just you protect the scalp by cooling and applying tourniquet. But even with this one, you still normally encounter alopecia, but they can actually reduce the incidence. So like during the chemotherapy, they can actually, you apply cooling, we call it cryotherapy. So this is a machine. This one is a tourniquet. Then by applying those techniques, you are going to minimize the delivery of the anti-cancer agents to the scalp, whereby they decrease the risk of damage to the hair. So those are the only prevention modalities we are going to introduce. Otherwise, there is no specific treatment modalities for alopecia as a result of chemo or radiotherapy. Are we together? So any questions so far? Any? So you're okay up to now? Huh?
Yes.
Okay, good. So the class is full, so make sure you attend. Now, renal toxicity. Yeah? Renal toxicity is very common with some class of drugs. So maybe can someone tells us which anti-cancer drugs are very notorious to cause renal toxicity?
Cisplatin.
Yeah, cisplatin, thank you. By the way, why cisplatin is specifically as compared to from platinum analogs, we do have cisplatin, we do have carboplatin, we do have oxaliplatin. Why cisplatin is more nephrotoxic as compared to the other one is because of pharmacokinetic property. By the way, the carboplatin and the cis oxaliplatin, they are highly bounded to the plasma protein. Remember, if a drug is actually highly bounded to the plasma protein, they cannot filter in the glomerulus because they be a big molecule and they cannot pass the atmospheric size of the glomerulus capillaries. So because they are highly protein bounded, but this platin is normally, it is usually it has lower affinity to bind. It is mostly free molecule. So it can filter out and affect the ascending loop of renal and the distal renal tubule. As a result, by the way, as a result, it can actually causes wasting of electrolytes, mainly potassium and magnesium are very common because it affects the site whereby magnesium and potassium is absorbed in the renal tubule. That is why cisplatin is highly nephrotoxic. It is less bounded to the plasma protein so that it can easily filter and causes the ascending loop of renal and the distal renal tubule in such a way it prevents electrolyte absorption in that site and causes depletion of electrolyte as well. Yeah, that is very important information to note. Then, when we think about renal toxicity, the most common drug we are thinking about is mostly cisplatin. So, if a patient is taking cisplatin, prevention therapy is very important. Make sure assess the baseline renal function or avoid any concrete use of any other nephrotoxic drugs. Then there is a pre-hydration therapy. The more you hydrate, now you are actually perfusing the kidney very well, so the possibility of elimination will be very high. That is why without perfusion of the pre-perfusion like before chemo with saline, normal saline, it is not allowed to give cisplatin. Then, apart from that, there is one treatment modality we call it forced diuresis. That means when you give highly nephrotoxic drugs, you normally consider to give diuretics so that you promote the urine output. So I don't think so. This one is commonly implemented in our setting, but the most common one is usually the nurses normally do hydrate the patient before giving cisplatin. But the other antidote, which I'm not very sure about the availability, is the organic phosphate chelates, which can actually bind with cisplatin, amipostin, but I'm not very sure about this one. So the most common treatment modalities in our setting is usually hydration of the patient, is the most common. Then I don't know, have you encountered any patient under chemotherapy having this problem, a peeling of the skin of the palm and the sole? We call it hand-foot syndrome. Is there anyone who came across?
So I didn't come across exactly this, but you see on the hands where they get the infusion, yeah, the veins become really dark, like it actually becomes black.
Oh, that one is most likely with extravasation induced cytotoxicity. Yeah. If you see there's very dark at the site of the infusion, means like there is minimum amount of leakage of vesicant toxicities, vesicant chemotherapeutic agents, mostly doxorubicin, that can cause chemical burn. It is just like if you put an acid on your hand, you'll encounter, if it is concentrated, you'll encounter a chemical burn. So similarly, if there is leakage of doxorubicin outside the veins, at the site of injection, you will see some chemical damage. Yeah, dark. Yeah, that is mostly extravasation. But when there is maximum extravasation, sometimes you'll see tissue necrosis. So what you have seen is most likely not really hand-foot syndrome, but it is normally extravasation. Yes.
Yes, sir, but when such a thing happens, and you know the cycles are many, like for the chemotherapeutic cycle, does the patient get injected on the same place, or like do they have to like look for other injection areas, or is it okay to just be injecting on the
It
same
is
area?
fine by there, but mostly they really change. But the best advice by they, if they're oncologists, like the more senior consultant, if they notice by they will actually make a lot of noise for the nurses. So this one is just because of inappropriate injection techniques. So that is why the oncology pharmacists, they are supposed to alert the nurses. But of course, most of the nurses, when they are working in the oncology areas, you cannot actually bring from the school and work in the oncology area. No, that one is not possible. So they have to undergo like a lot of practical training, even about the injection, the chemo mixing, and etc. Before they start practicing. So that is mandatory. So most of the nurses, by the way, they are very familiar with those toxicities. They are very familiar, by the way. I can even assure you, they are almost even more are like more equipped in terms by observation in terms of the side effects. So the best way is they normally look for another site, then properly inject if there is a leakage, because as I said, it can actually cause a tissue necrosis. But of course, we are going to discuss in detail when we're discussing about oncologic emergencies. Sometimes there is a need of even plastic surgery when there is like a lot of necrosis, because the tissue will die off. They are actually attacked by chemical and they are very sensitive. Yes. So, good question. Any other? I think someone normally raised and you have lowered. Other day you have lowered or?
So in a case where that has occurred, you just let it heal, or is there a way you can
Uh,
take
by
care
the
of
way,
it?
by the way, that is a good question. But of course, we are going to treat. But mostly, if it is mild, we just normally let it here. But there are some techniques we are going to employ. The moment you know there is extravasation, you are supposed to like wash it, the hands, remove like anything. That is the most common strategies we are going to employ. So if there is extravasation, you try to remove like that drug is from the site of injury without causing further damage. It is just like an acid. If acid drops on our hand, we're supposed to wash out immediately. Yes? So similar procedure is usually applied if they notice immediately. That is why most of the time we need to even give proper instruction to the patient about the specific side effect of their regimen. Remember, it is a combination regimen mostly they are taking, but from the regimen, some of the drugs they do have peculiar toxicities. So then the moment the patient they notice, they can inform the nearby healthcare practitioners. So if they don't notice, they just normally give time to heal. If there is maybe an ulcer, maybe they can consider topical antimicrobial agents to prevent further bacterial infection. And it's so mostly it is symptomatic because there is no specific antidote that can actually even, there is no specific antidote because it's just a chemical burn. Once the damage occurs, how can you reverse? And the damage is mostly very immediate, especially for basic cancer. Yes. Okay. Now, this hand-foot syndrome is the one, it is, as you can see from the image, there is peeling. Yeah? They are actually peeling of the skin of the palm and sole. That is why it is known as hand-foot syndrome. It is very common with capecitabine, the oral prodrug of 5-FU, the liposomal form of doxorubicin, infusional 5-FU, and weekly taxane. Do you know, by the I'm not very sure about the availability of liposomal doxorubicin, but comparatively, it is just like that of liposomal amphotericin B. So the liposomal doxorubicin has lower cardiotoxicity potential. If it is available, normally we prefer this one because of the cardiotoxicity. The conventional one increases like that of amphotericin B, but amphotericin B is renal toxicity. So those are very notorious. So if you see a patient has having on those regimen, we need to watch out the possibility of hand-foot syndrome. So treatment, dose reduction, despite it is not feasible all the time, because the moment you reduce the dose, you can actually reduce therapeutic effect. Avoid tight fitting clothing, avoid tight fit shoes, repetitive rubbing or prolonged to heat to hands and feet, and avoid then applying some emollient is usually recommended. So still for this one, there is no specific management we are going to give for the patient. But at the time of extravasation, we are supposed to remove as many the chemotherapy as we can. Okay, now the last point we are going to discuss is about chemotherapy-induced nausea and vomiting. So, cancer chemotherapy can cause nausea and vomiting by activating the vomiting center. So this one is among the most feared and the most commonly feared toxicities by patients undergoing chemotherapy. By the way, if you don't have adequate control of the nausea and vomiting in the first cycle, it is very hard to control in the subsequent cycle because of anticipatory emesis. So do you know about anticipatory emesis? So most likely, Dr. Larry mentioned you when he was discussing about nausea and vomiting. What does anticipatory emesis? So in case the patient encounter nausea in the first cycle, the moment they expect the second cycle, now there is actually like that anticipation will activate the vomiting center. It's very hard to control. It is just like pregnancy. Yeah. So if they notice nausea is caused by maybe because of the smell of the garlic or the onion. Now, the moment they smell, or even when they start cooking, they're actually anticipating like they're anticipating and there's a possibility of even nausea and vomiting before the garlic normally or the onion starts to smell. So this one is really very important, and we call it anticipatory emesis. So what is the pathophysiology of nausea and vomiting due to cancer chemotherapy? There are actually key receptors involved in chemotherapy-induced nausea and vomiting. There is serotonin receptor, which is located in the chemoreceptor trigger zone. There is emetic center of the medulla, GIT, and neurokinin receptor, so which is located in the emetic center of the medulla. So those receptors are highly involved or activated as a result of chemotherapy. But the most common key receptor is there is release of serotonin from the GIT. This activates what? Vomiting center. So, so because of that, we at the moment to give chemotherapy, this serotonin receptor is visually have important role in genesis of acute vomiting. So any vomiting that occur within 24 hours of chemotherapy is mostly due to serotonin receptor activation in the GIT. That is why serotonin receptor antagonists are the gold standard in the management of chemotherapy-induced nausea and vomiting, specifically in acute emesis. So an emesis that occur within 24 hours, we call it acute nausea and vomiting. Okay, so serotonin, when it is released, now there is activation, then the binding with this receptor, then there is activation in the emitting center. Okay, now this table is just to show you about the immunogenicity potential of anti-cancer medication. So you can actually even look at it carefully. Some of them, depending on the risk, some of them we call them high risk, moderate risk, and low risk. So high risk, greater than 90% of the patient will vomit without appropriate antiemetic. So this one, we have to give proper antiemetic. And mostly for highly emetogenic substances, we have to give combination of antiemetic agents. So the doxorubicin and cyclophosphamide, this combination is very common, and it is highly emetogenic. Cisplatin, even as low as low dose 40 milligram per meter square, is still has emetogenic potential. Cyclophosphamide, when you give high dose, dacarbazine, doxorubicin, when you give the dose is above 60 milligram per meter square, ifosfamide when the dose is above 2 grams. So that is highly emetogenic. Then the moderate emetogenic drug anti-cancer medication, they do have 30 to 90% risk. Carboplatin, cyclophosphamide with low dose, cytarabine, daunorubicin, actinomycin D, then doxorubicin, when we give low dose, it has lower moderate emetogenicity potential, and etc. Then the low risk is 10 to 30%. The capecitabine, docetaxel, doxorubicin liposomal, 5-FU, gemcitabine, they do have lower emetogenicity potential. So depending on the emetogenicity potential of the anti-cancer medication, we can actually consider various treatment modalities. Okay, now, what are the major causes or risk factors for nausea and vomiting? Poor control. I don't know why in female it is very common. In female, nausea and vomiting is very common as a result of chemotherapy, younger age, history of motion sickness, pregnancy-induced nausea and vomiting. So those are the major risk factor. Then, what are the clinical presentation of chemotherapy-induced nausea and vomiting? Some of them are acute, some of them are delayed, some of them are anticipatory, some of them are actually very breakthrough and very hard to control. So nausea and vomiting that occur in the first 24 hours of chemotherapy administration, we call it acute nausea and vomiting. So anything that occur between 24 hours to 5 days after administration of chemo, we call it delayed nausea and vomiting. Anticipatory emesis or nausea and vomiting is due to previous exposure or poor control in the previous cycle of chemotherapy. Now, the moment when you are trying to administer, the patient might have anticipatory nausea and vomiting. Then the breakthrough is, despite you give now appropriate regimen, you don't have any control. I think this one I've seen in a few patients, whatever antiemetic you are giving to them, you are not able to control the nausea and vomiting, and we call it even breakthrough nausea and vomiting. Sometimes they are going to even introduce haloperidol in case of breakthrough nausea and vomiting. Then how do we manage? How do we manage nausea and vomiting as a result of chemotherapy? Then ensure adequate sleep before treatment, very important. Then eating smaller meals and avoid greasy foods and food with strong odor because they can activate the vomiting center. So those are very important, but most of these kind of modalities might not be possible in our setting. So mostly they do prophylaxis, prophylaxis antiemetic agents. Okay, now let me ask you one question. Corticosteroids, they're actually one of the frontline medication, especially in the delayed nausea and vomiting, in control of delayed nausea and vomiting, dexamethasone. Now the question is, how does corticosteroids normally prevent nausea and vomiting? How does it prevent nausea and vomiting? Any trial? So how does corticosteroids normally prevent nausea and vomiting? What is your opinion? Duriti, are you in a position to try?
I to do with
Sorry?
affecting it's something to do with affecting prostaglandin synthesis.
Mm-hmm.
But I'm not sure.
Okay, good. But in which, by the way, the exact mechanism how dexamethasone can prevent nausea and vomiting due to cancer chemotherapy is not really known, but there are actually some proposed mechanism. The one which I was convinced about is dexamethasone normally prevent the expression of serotonin 3 receptor. So by blocking the expression of serotonin, it can actually prevent the binding of serotonin to serotonin 3 receptor. That is the most common and well known mechanism. Then apart from that, there is also involvement of inflammatory reaction that is responsible to cause nausea and vomiting in cancer patients. So dexamethasone, by preventing that inflammatory reaction, which has a potential to induce nausea and vomiting, it can reduce the risk of delayed and nausea and vomiting. So this one is mostly given for delayed nausea and vomiting. So don't be surprised when you see dexamethasone uh, chemotherapy, like the prophylaxis. We call them like pre-emetic or antiemetic or pre-medication before chemo. Yeah, but that is the role. just only for nausea and vomiting. And you have to know, how does a steroid normally prevent nausea and vomiting? Then serotonin receptor antagonist, I think this one is very straightforward because serotonin receptor is involved in nausea and vomiting, and urocanine receptor are also involved in the nausea and vomiting receptor, and olanzapine. Olanzapine, second generation antipsychotic, it has activity on dopamine receptor and serotonin, so it can be useful. I think this one is the only anti-cancer medication that has been approved in management of chemotherapy-induced nausea and vomiting. Okay, now the most common pharmacological treatment modalities is usually prevention. Prevention approach is very important. So for highly and moderate immunogenic drugs, we are supposed to give prophylaxis. Huh? Okay, now if we mostly by they give IV, like for ease of and for rapid onset of action in our setting, mostly they prefer to give IV route. So IV 30 minutes before chemotherapy. If it is given orally, you have to give like an hour before because of delayed onset of action when we use oral route. Dexamethasone is mostly for delayed, like day 2 and day 4, mostly after chemo administration for moderate and highly mutagenic drugs. Then the most common drug in our setting is the ondansetron. So mostly the 16 milligram IV dose is usually used because the 32 milligram is reported to extend QT interval of the ECG. Okay, because of that, the maximum dose we can give is usually 60 milligram when you give IV. And now, this one is the treatment algorithm or like the prevention algorithm for anti-medic medication. If the cancer medication is highly mutagenic, based on that list, now start with serotonin receptor antagonist, day 1. Usually we give like 30 minutes before IV. Then dexamethasone day 1 to 4 orally. Or aprepitant can also be considered, but what is very common is serotonin receptor antagonist and dexamethasone is usually the front line in the management. Or we can use olanzapine when instead of aprepitant if it is not available. But as I said before, 2 of them are the most commonly available and widely used. So the drug is moderately imitogenic. We still use serotonin receptor antagonist. Yes, on day 1, dexamethasone in day 1, or serotonin receptor antagonist day 1, and dexamethasone from day 1 to 3. So this is the strategy we are going to use. We can give serotonin antagonist alone, or dexamethasone day 1, or serotonin receptor antagonist day 1 along with dexamethasone for up to 1 to 3 days. But what is very common in our setting, as I said before, is they normally give dexamethasone. They normally give serotonin receptor antagonist before chemo, then they continue for 2 to 4 days with dexamethasone. That is very common strategy. Then for low, we can use dexamethasone or any other antiemetic agent like Placil can be used. But for low risk, we can actually use dexamethasone. But if the anti-cancer agents are actually having minimal risk, like less than 10%, we consider when necessary only. The guideline recommends if the drug has lower immunogenicity potential, you normally give when necessary only. Okay, fine. So this is how we're managing nausea and vomiting in cancer patients. So from serotonin receptor antagonist, we do have both granisetron and ondansetron. Both of them are available locally, but this one is widely available. So PO 16 to 24, IV 8 to 16 milligram is usually considered. Okay, so this is the dosing schedule, 8 milligram twice a day or 60 milligram daily dose. Oh, Palonsetron, I have never seen, I think two of them are the most widely available in our setting. Also, aprepitant is available in the guideline, but I have never seen in the practice. Then the other drug is dexamethasone. Yeah, dexamethasone PO, 12 milligram or 12 milligram IV. Then 8 milligram PO 2 to 4 days. That is the daily dose we can actually consider to give. Then maybe olanzapine is also can be given as 10 milligram daily dose. So this is the dosing schedule of nausea and vomiting due to cancer chemotherapy. Now, in the next 7 slides, now, Tiffany, question?
Yes, I have a question.
Yes, please.
In controlling emesis in cancer patients, we know they get different combinations of drugs. Some drugs have a higher risk of causing emesis than others. The dose of antiemetics like ondansetron or dexamethasone remains the same despite the regimen the patient is on.
Yes. But for highly emetogenic, normally you usually triple combination. The guideline recommends triple combination is usually recommended. Serotonin receptor antagonist, dexamethasone, and aprepitant, but still we are going to use the same doses. Remember, for ondansetron, we cannot give like more than 32 milligram, like the 60 milligram IV and 24 milligram orally because of the QT interval prolongation. So when you have highly metogenic drugs in the regimen, have many combination and give longer duration for dexamethasone, maybe you continue up to 4 days. Yeah, that is the usual recommendation. So if they are still actually vomiting, normally even they continue even serotonin receptor antagonists even for a few days. Yeah, that is how they are managing.
Okay, so thank you.
Okay, good. Any other question? Now, yes, please.
Are there any psychological side effects of chemotherapy?
Psychological side effects, in a sense, is it like the psychiatric aspect?
Yes.
Oh, no, not really, by the way. Not really, most of them. But when the patient is actually worried about their condition, there is high probability they can develop psychiatric disorder. Yeah, like the negative impact, like about there actually a lot of stress. So there are a few of days when they are sick. Yeah, that condition, like the environmental condition and their condition, can actually even increase risk of mental illnesses. Otherwise, the drug by itself, it is very likely to produce mental issues.
So I have a question in related to that. I've also seen a patient who who I don't know whether to attribute he had mental, like he lost it's kind of like amnesia for a few days after going going for chemotherapy. So maybe it was a drug or something like
Which
that.
regimen? I don't know which regimen the patient was on. You and maybe if you do have the information.
I'm not really sure, but he was being treated for prostate cancer.
Prostate cancer.
Yeah.
Okay. Okay. I don't think so. Anyways, maybe. Okay. Maybe just give me. Oh, okay. The guideline I'm referring now is telling me there is a possibility of short-term memory lapse, difficult remembering names and date, and problem in concentrating. Then research normally has linked memory issues to a certain chemotherapy drugs prescribed to the breast to the treatment to treat many type of breast cancer. So I think there is some kind of short-term memory loss as a result of the chemotherapy. Yeah, yes. So it might be due to, but what kind of chemotherapy the patient was taking when they are on prostate cancer? Because most of them, we are normally using hormonal therapy. Was he on chemotherapy on it?
Yes, maybe I confirmed the drugs he was on because he's finished his cycles last week, but he did suffer from like memory loss, short-term memory loss, and hypoglycemia.
And hypoglycemia.
Yeah, yeah.
Okay. By the way, the cancer normally can actually cause, yes. Some cancers normally they are like weight loss, cachexia, etc. But please kindly confirm if you are able to get what regimen the patient is on, because most of the time, like for prostate cancer, unless they are androgen resistant or castration resistant prostate cancer, we don't give chemotherapy. And the most commonly given chemotherapy is usually docetaxel along with dexamethasone. Dexamethasone or prednisolone, I'm not very sure which one it is, but docetaxel is the only chemotherapy we are going to use in prostate cancer. So kindly confirm for that one. But for this one, from my preliminary research, there is a possibility of some memory lapse with some chemotherapy regimen, but with chemo, not hormonal therapy. But for that one, maybe I will check.
Okay.
Good observation, by the way. It is good observation. Any other question? Any other?
So when you start the treatment and then the patient undergoes through all of these, maybe the complications of these side effects of the drugs, how do you like, I don't know, motivate them or encourage them to keep going? Because like you can see what, when you're trying to solve one thing, you need to cover it up with another drug because some other thing can arise and some other one can arise. And most of the time, like especially from the trends nowadays, there's so many people who are against chemotherapy. When they're actually diagnosed with cancer, they would say they would rather not go through that and they just give up on it even before the treatment comes, because they've observed from previous experiences that it just leads to more damage than more good. So how do you even like counter that?
Good question. But for sure, when you see the real practice, uh, so like my experience is only in KNH, then in my country, but my country is not like longer. It's just only like 9 months experience in the oncology part. But when I see here, they do have many patients, even they don't really have time even to give proper counseling. So that is why the aspect of psychotherapy is very important, very important. But and very important, by the way, yeah. But mostly that one is not possible to deliver in our setting because the clinicians are very few. So, but the psychotherapy is actually very important. I think nowadays, I don't know whether you have seen, we do have the clinical psychologists actually providing proper counseling for terminal illnesses like that of cancer. So otherwise, it's not really very important. But how it is possible, but within a proper setting, you can actually deliver proper counseling, then proper acceptance of the treatment. Even the disease is also important, like what we do for HIV patients. But it's very hard, like as you think. Tiffany?
I also have a question with regard to the psychiatric aspect of things. So if you have a patient who after getting the diagnosis develops maybe depression or such a condition because of the environment and the stress, like you said, are you supposed to treat it pharmacologically? Is there what is it, protocol in terms of which one you begin with, or is it just supportive care and counseling due to the interactions you see between some of the anti-cancer drugs and drugs like antidepressants?
Good by the way, but mostly depending on the severity of the illness. If it is severe, they initiate pharmacological therapy. But most of the time nowadays, when they suspect mental illness, they go to directly to the medication. But depending on the condition. But if they develop depression, if they do have like real diagnosis, like if they actually meet the diagnostic criteria for depression or any psychiatric illness, they're supposed to initiate pharmacological therapy along with non-pharmacological treatment. It's very common. You will see like some patients that are having other medical condition, then later on they develop psychiatric illness, but they are on antidepressant or any other medication. Yeah, that is true. Then mostly they refer to psychiatrists. The moment they encounter that, they usually refer to psychiatrists, then the psychiatrist will assess. Then after their review, now that is when they are going to commence the treatment.
Okay, sir. Thank you.
Yeah, Noor?
Okay, I also have another question. Like when it comes to these complications for chemotherapy, I've observed one where there's like edema. How do you like counter that, or you just ignore?
Okay, by the way, what is very common, if it is edema, mostly like we have to know whether that edema is due to the chemotherapy or not. Yeah, due to the chemotherapy or not. That
It
is why.
happens mostly after the chemotherapeutic cycle, like immediately after the chemotherapy is administered, like maybe within 2 days or something, there's edema and especially angioedema on the face.
Oh, okay. But edema is very common with docetaxel. Yeah, that is the most notorious drug that can actually even cause edema. For that one, even the recommendation is maybe you switch to another alternative medication or alternative chemo regimen if the edema is due to cancer chemotherapy. So most of the time, if there is an edema, which is mild, if mild, they normally monitor. If it is mild, they just monitor. If severe, they can actually even hold the second cycle. Yes. Otherwise, if it is very severe and affecting maybe the other organs, maybe they can consider, they can actually even consider other treatment modalities. But the kind of angioedema is, it can be even hypersensitivity reaction with the medication, and sometimes they introduce steroids in the management or maybe antihistamine to prevent that hypersensitivity reaction. So like the treatment will be depending on the nature of the disease. Yeah, so those are the possible options that can actually, so if the edema is due to maybe, if a patient is taking taxane-based regimen and cause edema, so the best way is normally consider to give antihistamine steroids because it is related to hypersensitivity reaction due to the drug. Okay, so that is the strategic we are going to employ. Noor. Okay, any other question? Okay, now, if you don't have any question, maybe we shall see those small case studies that are actually very simple, and we shall see it together because of time before we close this chapter. So, fine. So let me lead you because we have only 20 minutes to end the session. So like this patient is actually a 60 years old a patient with no significant past medical history. So she complained cough, shortness of breath. Then chest radiology reveals there is actually a lesion in the right lobe of the lung. Then they do surgical resection in cytology. Examinations are positive for non-small cell lung cancer. So this patient was having a lung cancer according to the cytology report. Then they did a workup and there is no metastasis. So that means like the disease is still localized. Then the diagnosis was made with early stage 2 non-small cell lung cancer. Then the physician wants to initiate adjuvant chemotherapy. Remember why adjuvant? They have already done the surgical resection. Adjuvant, but the moment they do the resection, they do cytology to undergo screening. Adjuvant chemotherapy of carboplatin targeted area of under the curve AUC of 6 milligram per ml per minute on day 1 and paclitaxel 200 milligram per meter square. By the way, I shall discuss about the dosing of carboplatin. The carboplatin dosing is usually calculated based on Calvert formula. So Calvert formula. So this formula is area under the curve of targeted area under the curve of the drug, then times in bracket GFR plus 25. So we can actually get the dose of carboplatin in milligram. So the dose of carboplatin in milligram is equals to area under the curve of the area under the curve. According to different protocol, they normally give different area under the curve, 6, sometimes 4, but usually between 4 and 6 is very common. Then we calculate the GFR, then plus 25, then we'll get the dose of carboplatin. So that is this is what is telling about the area under the curve of 6 milligrams. So if we know this one, we're supposed to know the GFR in order to calculate the dose of carboplatin. Now, so the regimen of adjuvant therapy for this patient is combination of carboplatin with paclitaxel. Now, discuss the toxicities that might be expected to occur with this regimen. So what kind of toxicities are you expecting with this regimen?
I think a high risk of myelosuppression because it said carboplatin itself causes has a high risk of causing myelosuppression, and then taxanes as well.
Yes, high risk of myelosuppressions are usually expected. Okay, good. Then what factors normally what factors can influence the incidence and severity of those adverse effects? What factor can influence the incidence and severity of those toxicities?
Can you say age?
Yeah, yes, patient age. The older age, normally the higher risk. Then the bone marrow reserve, yes, in case if the patient was having some problem, the bone marrow before, degree of myelosuppression from the previous cycle, then any radiation therapy, and the ability of the liver and the kidney to metabolize and excrete the administered drug. So those are some of the factors that can influence the possibility of having these ADRs. Okay, so like as you said, myelosuppression will be the most expected ADR for this patient. Still a continuation. Now, about 9 days after the first course of chemotherapy, JT experiences severe sore throat and fever. Look at about the sore throat and fever. He was admitted to the hospital and treated with IV antibiotic. Then at that time, his WBC count was 300. And the absolute neutrophil count is 50 cells per microliter. The platelet count was still low, and hemoglobin is just 11. So if you see, normally which blood cell was affected, like from the result after chemo, like after 9 days of chemotherapy, can you see normally like his WBC count was low, absolute neutrophil count is normally low, and even the platelet is low. Was it true normally what I said before? Like myelosuppression, the first blood cell that is affected is normally what? The first blood cell that is affected is the neutrophil. You can see the NAC is actually very low. Then the platelet, because the patient's already 9 days, so we're expecting even thrombocytopenia. And hemoglobin is not really severely affected. It's just normally slight derangement in hemoglobin level. Huh? Okay, now his fever resolved after 3 days, and all cultures were negative for bacterial growth. Now it is now 3 weeks after chemotherapy, and he is scheduled to receive the second course. Should he receive the same dose he was given initially? And what was your opinion? What was your opinion? This is the parameter. Remember, this was the blood parameter. Now is about to start the second chemo, and the regimen is usually administered like the carboplatin paclitaxel regimen for lung cancer is administered every 3 weeks. Yeah, so that we give time for the bone marrow to fully recover. So, what is your opinion? Is he supposed to take the same regimen, or what is your opinion? Any opinion? Okay, fine. Now, when you look at the blood parameter, it seems like there was a derangement in the blood parameter. So there is an option we can reduce the dose by 25% in subsequent cycle. But the problem is it can actually compromise the response and survival of the patient. So because JT's cancer is a both chemosensitive and potentially curable, by the early stage non-small cell lung cancer is usually very sensitive for chemotherapy, dose reduction is not really desirable or undesirable. Because if we reduce the dose, the possibility of cure is very minimal. So to minimize the risk of neutropenia with future therapies, now the patient is supposed to be given granulocyte colony stimulating factor, cadmium mixture, to prevent potential complication associated with neutropenia. So this one will be the most viable strategy with monitoring. But if in subsequent cycle, if it is very low, but of course sometimes we reach at a point where we're supposed to even hold the treatment. Then the other question is, how should this colony stimulating factor should be dosed in JT to reduce the severity of chemotherapy-induced neutropenia? So the most common regimen we're having in our setting, as I said, is Nipogen. Then it is usually given single dose subcutaneously, and mostly for adult patients like JT, 300 microgram per day subcutaneously until the neutrophil count is above 2000 is supposed to be administered. By this one, according to various studies, the moment we give colony stimulating factor, like 24 hours after chemotherapy, the possibility of neutropenia will be very minimal. So that is why we have to give for this patient and continue the chemotherapy. Okay, now, if JT was not given filgrastim and presented with febrile neutropenia, would CSF therapy be helpful? According to different randomized controls here, for the prevention, the role is very significant. But when the patient is developed febrile neutropenia, it has minimal to moderate benefit in reducing hospital stay and no difference in mortality. This was the evidence according to randomized control trial study. So it is good and very effective when you give them the prevention and instead of giving the treatment, especially with filgrastim. That is why for highly toxic regimen, and after they are assessing the bone marrow, like the peripheral blood, are going to consider initiation of this medication. Okay, how long until the duration of neutropenia is resolved? Now, another point to note, 14 days after his first course of chemotherapy. Remember, sometimes we say course, sometimes we call cycle, but nowadays I think they usually say course of chemotherapy. GT platelet count. Initially it was 1 or 2. Huh? Have you seen it? Initially it was 1 or 2, if you remember, 102,000. Yeah? Now it's already 7,000. We are even expecting bleeding. But a platelet count below 20, you expect even bleeding. Most patients, they bleed. Now he has no evidence of bleeding. Of course, he has no evidence, but the platelet count is like 7,000. The clinician decides to administer a prophylactic platelet transfusion. What is the most likely offending agent for this patient to have low platelet count? By the way, which one is the most offending agent to cause a low platelet count for his regimen? What is your opinion? Is it carboplatin or paclitaxel? Any opinion?
Carboplatin.
Why you say carboplatin? Remember, carboplatin is normally notorious to cause myelosuppression. So even after causing myelosuppression, the most blood cell that is affected by carboplatin administration is usually platelet count. That is why thrombocytopenia is actually very severe after a cumulative myelosuppressive effect of platelet precursor due to carboplatin. But then if you see a regimen of carboplatin plus any other regimen, and if you see very severe thrombocytopenia, the most likely offending agent is usually carboplatin. But it's very common after many cycles of chemotherapy. Okay, good. I think this is the last slide. Then after that, we discuss kidogo about the rotation, then that will be the end of the session. Now, CW is a 40 years old woman with breast cancer. She underwent lymph node dissection and lumpectomy. That means they just remove only the site of the tumor. She receives 20 fractions or course of radiotherapy to the affected breast. She will also receive chemotherapy to minimize the risk of recurrence. She is in the clinic today to receive the first 4 cycles of doxorubicin, a cyclophosphamide regimen. I think this one is the most common regimen in our setting, even in the management of breast cancer. So although CW has a minimal problem with surgery, now she is very fear of receiving the combination chemotherapy. You counsel CW about the most common toxicities by reviewing the likelihood and the management of myelosuppression, nausea, and vomiting. Now, CW is appropriately attentive as you discuss those issues with her. However, her overriding concern is whether or not she will lose her hair. She is actually very concerned about her hair. The CW concern is typical of most cancer patients. And how do you respond? So in the first place, are we expecting her loss with this regimen?
Yes.
Yes. Okay, good. So do you think it is a concern, typical concern for most cancer patients?
Yes.
Because most of the ladies are very concerned about the hair loss, but the risk outweighs the benefit anyways. So how do you respond to her? You know, this one is just like not objective question, it is subjective, so it can be, the answer can be any. So how do you respond to her?
I will ask her to be prepared And like if she's scared, she could try like shaving her hair. Yeah.
Okay, good. Any other maybe response you can give to her?
Yeah, I'll provide a solution.
What solution?
There are many, you have to check your head type and how your head is shaped. If it's someone who is bad, they can opt for a wig that will make them look prettier, because emotionally you also want to motivate them to take the treatment. And also by doing that, maybe the wig can provide a temporary solution. And if their head shape allows them not to have hair and still be pretty, then you encourage them and tell them you can do this, and keep checking up on them. Now I understand.
Oh, thank you, Joe and Kitinji. Okay, good. Angela, what advice you want to give?
I would also say the same, like advise them to get a hair piece, like the wigs, or wear turbans or hats if they feel uncomfortable going out with the head being bald. And also encourage them that after the treatment is done, the hair will grow back eventually.
Okay, good. That is really proper advice normally, yes. I think if she's really very concerned, like the hair wigs will be like the most viable option for her. And thank you so much for your proper counseling for our patient. Okay, now that would be the end of the introductory session for cancer chemotherapy and principle. So maybe if you have any question, you are welcome. Any question?